Think about this for a second. Right now, if you are 65 years old in America, you have health insurance. Not because you chose it, not because you could afford it, not because your employer offered it. You have it because the federal government decided in 1965 that leaving elderly Americans to face the cost of medical care entirely on their own was not a policy the richest nation on earth could continue to defend. Medicare. It covers hospital stays, doctor visits, surgeries, prescription drugs. Most people think of it the way they think of oxygen. It's just there. It's the background hum of American life for tens of millions of senior citizens. And we've come to treat it as though it has always existed. As though some wise ancestor wired it into the foundation of this country from the beginning. But here's the thing. Medicare didn't exist until July 30th, 1965. And before that date, being old in America meant something completely different. It meant navigating a medical system with no safety net, no guaranteed coverage, and no protection against the catastrophic costs that come when a human body begins to wear down. It meant making impossible choices. Between medicine and food, between a hospital bed and the rent, between asking for help and dying quietly with your pride intact. So the question becomes, if Medicare didn't exist for most of American history, what happened when elderly Americans got sick? Who paid? Who treated them? And what had to go so disastrously, so publicly, so undeniably wrong that the federal government finally stepped in after decades of furious political resistance and completely transformed how this country handles medical care for its oldest citizens? To answer that, we need to go back. Way back. To a time when the question of who pays for your health care wasn't a political debate. Because for most of American history, there was almost nothing to pay for. Let's start with the medicine itself. For most of the 19th century, American medicine was, to put it plainly, not very good. Germ theory wasn't formally established until the 1860s and 1870s. Before that, doctors operated on explanations for disease that we would today recognize as folklore, bad air, imbalanced humors, the miasma rising from swamps and rotting garbage. Treatments were often as dangerous as the diseases they were meant to cure: bloodletting, purging, mercury-based compounds, opium tonics. A trip to the doctor in 1850 was about as likely to make you sicker as it was to make you better. This matters because it shaped how Americans thought about medical care and its cost. If the treatment wasn't reliably better than doing nothing, why would you pay much for it? And most people didn't. Medical care in the early 19th century was cheap. Not because the system was efficient, because it wasn't worth much. A home visit from a country doctor might cost 50 cents. Medicines were largely home remedies passed between generations. Surgery was performed on kitchen tables. And patients who survived did so mostly on luck and the sheer resilience of the human body. For the elderly in this era, sickness was simply part of the slow process of dying. You got old. Your body failed. Your family cared for you at home until you either recovered or didn't. There was no hospital to go to, no specialist to consult, no intervention that modern medicine would recognize as treatment. Death came as it always had, in the bedroom of the house you'd lived in for 40 years, surrounded by the people who loved you. It was brutal by modern standards. But it was also low cost by design. And then something happened that changed everything. The practice of medicine got dramatically better, and dramatically more expensive. The late 19th and early 20th centuries saw an explosion in medical knowledge and capability that no one fully anticipated. Anesthesia arrived in the 1840s, making surgery survivable in ways it had never been before. Pasteur and Koch established germ theory, making it possible to understand and eventually prevent infectious disease. Antiseptic technique transformed operating rooms from charnel houses into places where patients had a reasonable chance of walking out alive. X-rays were discovered in 1895, giving doctors their first look inside living bodies without cutting them open. Vaccines brought under control diseases that had killed millions for centuries. By the turn of the 20th century, medicine had transformed from an art of uncertain comfort into something approaching a genuine science. And the hospital, which had for most of human history been primarily a place where the poor went to die, was becoming a center of real therapeutic care. For the first time in human history, going to a hospital might actually save your life. But this transformation came at a price. Modern medicine required equipment, trained personnel, sterile facilities, specialized knowledge. All of it had to be paid for. And as medicine became more effective, it also became more expensive. The question of how ordinary Americans would pay for this increasingly capable but increasingly costly system would define the political battles of the next 100 years. For elderly Americans specifically, this created a crisis with a slow fuse. The people who needed medical care most, those whose bodies were oldest and most prone to failure, were also the people least likely to have steady income. And they were the least attractive customers to an emerging private insurance industry that was learning to make money by insuring the people least likely to get sick. Now, in the early 20th century, if you were an elderly American who needed medical care, you had a few options, and none of them were good. The first and most common was simple self-reliance. You paid out of pocket, in cash, directly to the doctor or hospital. For minor illness in younger years, this might be manageable. But for serious illness in old age, a broken hip, a heart attack, pneumonia, cancer, the costs could be catastrophic. Medical bills could erase a lifetime of savings in a matter of weeks. The second option was charity. Many hospitals in the early 20th century operated on a two-tiered system. Wealthy patients paid for private rooms and private nurses, and in doing so quietly subsidized the care provided to indigent patients in the charity wards. These charity wards were functional but grim. Large open rooms with rows of beds, minimal privacy, overworked nurses, and a pervasive, crushing atmosphere of shame. Because in early 20th century America, needing charity care meant you had failed. It meant you were a burden. That shame was not incidental. It was structural. It kept people from seeking care until their conditions became emergencies, which made those conditions far more expensive and far harder to treat. The third option was the almshouse, the poorhouse. We've talked about these in the context of retirement before, but they were equally relevant to medical care. The poorhouse served as America's default safety net for anyone who could not support themselves. That included the sick elderly who had no family to care for them and no money to pay for treatment. The conditions were what you'd expect from an institution designed more to deter dependency than to provide genuine care. Think about what it meant. You worked your entire life. You built something, raised children, contributed to your community, and then your body started to fail, as all bodies eventually do. And the system's answer was, spend your savings, then spend your children's savings, then ask for charity, and then, if all else fails, go to the poorhouse. That was the American healthcare safety net for elderly citizens for most of this country's history. Not a net at all, really, more like a cliff. The private health insurance industry, when it finally began to emerge, did almost nothing to change this. And the reasons were purely economic and entirely predictable. The first recognizable health insurance plan in America was born in 1929. A group of Dallas school teachers made a deal with Baylor University Hospital. They would pay 50 cents a month in exchange for up to 21 days of hospital care per year if they needed it. Simple, elegant, and it worked. Other hospitals quickly adopted the model. By 1932, these hospital-sponsored plans had united under a symbol and a name that would become one of the most recognizable in American healthcare. Blue Cross. Blue Shield followed, covering physician services rather than hospital costs. And in the post-World War II economic boom, as employers competed fiercely for workers in a tight labor market, offering health insurance as a workplace benefit became standard practice for large companies. By the mid-1950s, private health insurance was widely available. But available to whom? To working people. Specifically to working people whose employers offered group coverage. Because group insurance was how private insurers made money without going bankrupt. In a group plan, the insurer covered everyone, the healthy 25-year-old and the 55-year-old with high blood pressure alike. The healthy people subsidized the sick people, and the math worked because the healthy people outnumbered the sick ones. But elderly people, people who had retired, who no longer had an employer purchasing group coverage on their behalf, were stranded. They were exactly the wrong kind of customer for private insurance. Old, increasingly likely to be sick, increasingly expensive to treat. The private market's answer to the question of how to insure the elderly was simple. It didn't want to. Individual insurance policies for elderly Americans in the 1950s were either unavailable or available at premiums so high they were functionally unaffordable for people living on fixed incomes. A 1959 survey found that fewer than half of Americans over 65 had any health insurance at all. And even those who had coverage often found it dangerously inadequate when serious illness arrived. Policies were riddled with exclusions, pre-existing conditions, and at 65, nearly everyone had something that qualified, were routinely denied. Lifetime maximums were low, and when the bills arrived for a serious hospitalization, the fine print left policyholders covering far more than they had expected. The numbers told a brutal story. In 1963, the average elderly American spent approximately $445 a year on health care. That was twice what the average non-elderly adult spent. And while that might not sound enormous in isolation, consider that the median annual income for elderly Americans at the time was only about $1,000. They were spending nearly half their income on medical care in an average year. A serious illness, a stroke, a cancer diagnosis, a surgery that couldn't wait, could dwarf those numbers in weeks. And yet the political road to Medicare was one of the most fiercely contested in American legislative history. The battle lasted nearly 3 decades. And the resistance came not just from insurance companies, but from within the ideological fabric of American life itself. The first serious push for national health insurance didn't come in the 1960s. It came in the 1930s, during the same New Deal era that produced Social Security, when Franklin Roosevelt's Committee on Economic Security was designing Social Security. In 1934 and 1935, health insurance was on the table. Roosevelt himself was sympathetic, but the American Medical Association, the AMA, was furiously opposed. The AMA had been the dominant force in American medicine since its founding in 1847. It had spent decades consolidating the profession's power, prestige, and income. The idea of government-controlled health insurance threatened everything the AMA stood for. Physician autonomy, fee-for-service medicine, the doctor-patient relationship free from bureaucratic interference. The AMA launched one of the most aggressive lobbying campaigns in American history. They called it socialized medicine. They warned it would destroy the quality of American health care, that it would turn doctors into government employees, that it was a step toward communism. These weren't just talking points. They were deeply held beliefs, and they resonated with a significant portion of the American public and the Congress. Roosevelt, unwilling to sacrifice the rest of his New Deal agenda over this fight, dropped health insurance from the Social Security Act entirely. President Harry Truman tried again in 1945 and 1948. He proposed a comprehensive national health insurance plan as part of his Fair Deal. The AMA's response was ferocious. They hired a public relations firm, one of the first major deployments of professional political PR in American history, and launched a campaign that spent what would today be tens of millions of dollars on pamphlets, posters, advertising, and lobbying. The slogan was deliberately simple and deliberately powerful. The voluntary way is the American way. National health insurance, the AMA argued, was un-American. It was the kind of thing they did in the Soviet Union. Truman's plan went nowhere. Through the 1950s, the political battlefield shifted. Rather than fighting for comprehensive national coverage, reformers began focusing on a narrower and harder to argue with target. Just the elderly. Just Medicare. The logic was difficult to dismiss. The elderly were the group most clearly abandoned by the private market. They were the group most visibly suffering. And politically, they were increasingly organized, increasingly vocal, and increasingly impossible to ignore. The statistics from the late 1950s and early 1960s were damning. A 1961 Senate subcommittee survey found that 51% of elderly Americans who were not in nursing homes had no health insurance. For those who did, coverage was often dangerously thin. The average elderly American in poor health spent more than 20% of their income on medical care. And when serious illness struck, The financial devastation could be total. Life savings gone in months, property sold, children's resources drained, a retirement reduced to poverty. These weren't abstractions. They were stories that every American family knew. A grandmother who put off surgery because she couldn't afford the bill. A grandfather who chose between his heart medication and the grocery money, and chose the groceries because you cannot get by without eating. The crisis was personal and visible, and it was happening in every community in the country. President John F. Kennedy made Medicare a priority. The AMA responded with renewed ferocity. In 1961, they launched a campaign called Operation Coffee Cup, in which doctors' wives were recruited to hold coffee gatherings in their neighborhoods, play a recording made by a young actor and political spokesman named Ronald Reagan, and urge their guests to write letters to Congress opposing socialized medicine. Reagan's voice warned gravely that if Medicare passed, we would one day be telling our children and our children's children what it was once like in America when men were free. Congress remained deadlocked. Kennedy couldn't move the votes. And then, November 22, 1963 happened in Dallas, and John Kennedy was gone. Lyndon Johnson took the oath of office on Air Force One with Kennedy's widow standing beside him in her blood-stained pink suit. And if there was one thing LBJ understood above anything else, it was power. How to accumulate it, how to spend it, and when the moment had arrived to use everything he had. The 1964 election gave Johnson one of the most overwhelming mandates in presidential history. He won 44 states and more than 61% of the popular vote. Democrats gained 37 seats in the House, and LBJ was not a man who let opportunities pass. He moved immediately. On January 7, 1965, the 89th Congress convened, and Johnson made Medicare the first order of business. The political maneuvering that followed was a masterclass in legislative strategy. When Ways and Means Committee Chairman Wilbur Mills, who had blocked Medicare for years, finally signaled he was ready to move, Johnson seized the moment. The bill that emerged was broader than anyone expected. Mills had taken 3 competing proposals: the administration's Medicare plan for hospital coverage, a Republican alternative covering physician costs, and a Democratic plan expanding coverage for the poor, and combined them all into a single package. It was a masterstroke. By giving everyone something, he made it nearly impossible for anyone to vote against. On July 28, 1965, the House passed Medicare 313 to 115. The Senate followed 2 days later, 68 to 21. And on July 30, 1965, President Lyndon Johnson flew to Independence, Missouri to sign the bill into law in the presence of Harry Truman, the man who had first proposed national health insurance 20 years earlier. Truman and his wife Bess became the first 2 Medicare enrollees in the country. The scene was deliberately, carefully symbolic. Johnson understood what was happening. He was closing a chapter of American history that had stretched back to the poorhouses of the 19th century and the charity wards of the early 20th. He was writing into law the first federal guarantee that growing old in America would not mean being left medically defenseless. The scale of what followed was staggering. Medicare went into effect on July 1, 1966. In that first year alone, 19.1 million Americans over 65 enrolled. Think about that number for a second. 19 million people who had spent decades navigating a healthcare system with no guaranteed coverage were suddenly enrolled in a federal insurance program. Hospitals that had been quietly absorbing elderly patients as charity cases suddenly had a paying customer. Doctors who had routinely written off elderly patients' bills suddenly had a reliable payer. The financial mechanics of American healthcare shifted overnight. The immediate effects were dramatic and visible. Hospital admissions for elderly Americans rose sharply in the first years after Medicare, not because old people had suddenly gotten sicker, but because they were finally seeking care they had been deferring for years. The postponed surgery was now possible. The specialist referral was now affordable. The pent-up demand of a generation of Americans who had been rationing their own medical care came flooding into the healthcare system all at once. And the health outcomes were measurable. Studies conducted in the decades following Medicare's passage found significant reductions in elderly mortality rates, particularly from conditions, heart disease, pneumonia, chronic illness, that responded most to timely and consistent care. One landmark study estimated that Medicare reduced elderly mortality by 13% in its first decade. These were not statistics in a vacuum. These were lives. Mothers and fathers and grandparents who were alive because the federal government had decided they deserved health care. But the story of Medicare, like the story of every major American social program, is not purely a triumphant march. There is a darker thread running through it, and it is about who was included, who was left out, and why. The Medicaid program, created alongside Medicare, was designed to cover the poor of all ages. But in practice, its implementation was deeply uneven. States were given enormous latitude in setting eligibility thresholds and benefit levels, and many southern states set those thresholds so low that huge portions of their poor populations were excluded entirely. Black Americans, disproportionately poor and disproportionately uninsured, were supposed to benefit most from Medicaid. In practice, the combination of state control and systemic racial bias meant coverage was far from universal. And even Medicare itself operated inside a healthcare system that was far from integrated. Many hospitals in the South were still racially segregated in 1965. Medicare's architects understood this, and they used the program as a lever. The law required hospitals receiving Medicare funds to comply with the Civil Rights Act of 1964, which prohibited racial discrimination. This gave federal administrators an enforcement tool they had previously lacked. In the months leading up to Medicare's July 1966 launch, teams of federal investigators fanned out across Southern hospitals. They inspected for compliance and threatened to withhold Medicare certification from facilities that refused to integrate. The financial incentive proved more persuasive than decades of moral argument had been. Hundreds of Southern hospitals desegregated in the spring and summer of 1966, specifically to gain access to Medicare dollars. It was, as historians have noted, one of the fastest and most sweeping hospital desegregation efforts in American history. And it was driven by money. Now step back and consider the full arc of what we've traced. From 1900 to 1965, the question of how elderly Americans paid for health care went from a personal problem managed through savings and family sacrifice in charity wards and poorhouses, to a structural crisis visible in the suffering of millions of American families, to one of the most contentious political battles in American legislative history, to the creation of a federal program that now covers more than 67 million Americans. Medicare today is not simply a health insurance program. It is the single largest purchaser of healthcare in the United States. The way it pays doctors and hospitals, the billing codes it uses, the prices it sets, the procedures it covers, shapes the entire structure of American medicine. Private insurers routinely peg their own payments to Medicare rates. Hospitals design their facilities around Medicare's reimbursement logic. Medical schools train physicians to document care in ways that satisfy Medicare's administrative requirements. The federal government, through this single program, has become so deeply embedded in the American healthcare system that separating the two is essentially unthinkable. And yet, the system faces tensions that are not going away. Medicare confronts an existential financial challenge. The baby boom generation is aging, and the ratio of workers paying into the system relative to retirees drawing from it has been shrinking for decades. In 1966, there were approximately 4.6 workers for every Medicare beneficiary. Today, that number is closer to 3.3. By 2035, it is projected to fall below 2.5. The math of a pay-as-you-go insurance system gets harder every year as the population ages. Prescription drug coverage, absent from the original Medicare program, wasn't added until 2003, and its implementation through private insurers rather than direct government negotiation left it substantially more expensive than it needed to be. The Inflation Reduction Act of 2022 gave Medicare the authority to negotiate drug prices directly for the first time, decades after most other developed nations had taken that step as a matter of course. It is worth noting, too, that the United States arrived at Medicare later than almost every comparable nation. Germany established national health insurance in 1883. The United Kingdom created its National Health Service in 1948. Canada implemented universal health coverage for the elderly in 1957. By the time LBJ signed Medicare into law in 1965, America was one of the last wealthy democracies to provide any government guarantee of health care for its elderly population. That pattern, arriving last, covering less, paying more, is a product of political compromise rather than rational design. It is what happened when the push for universal coverage repeatedly failed, and reformers retreated to what was politically survivable. Every step forward was resisted by some version of the same argument: government overreach, socialized medicine, the end of freedom. The arguments changed their vocabulary with the decades, but the structure remained constant. And every step forward was also a step that left someone behind. The 30-year mortgage changed who could own a home. Social Security changed who could survive retirement. Medicare changed who could afford to get sick while growing old. None of these are natural features of American life. They are inventions, political choices made in specific historical moments by specific people who decided that leaving their fellow citizens to face these crises alone was not the kind of country they wanted to live in. And understanding where Medicare came from, the charity wards and the poorhouses, the AMA's Operation Coffee Cup, the 19 million seniors who enrolled on the very first day, helps us understand not just why it exists, but what it cost to build and what it would mean to lose. The next time an elderly family member schedules a routine checkup, or walks into a surgeon's office, or fills a prescription and takes it for granted that the bill will be covered, that moment of ordinary confidence is the entire point. It is what 7 presidents tried and failed to create. It is what organized medicine spent 3 decades and enormous sums of money trying to prevent. It is what Lyndon Johnson fought for as hard as he fought for anything in a life spent fighting. It did not always exist. It had to be invented. And the fact that it works, that it has worked for more than 60 years and for tens of millions of people, is one of the most consequential achievements in the history of American social policy. But it is also a system built on compromises that left millions behind, that remains structurally vulnerable, and that still does not reach everyone who needs it. Understanding that is not a reason for cynicism. It is an argument for continued attention. Because the story of Medicare is not finished. It never is. If this kind of deep dive into the hidden history of American institutions is what you come here for, please subscribe. It takes real time and real work to research and tell these stories with the depth they deserve, and every new subscriber makes that possible. And if you haven't seen it yet, check out this video right here. I think you'll find it just as surprising as this one.